Okay, so you can scan the Menti with your phone, or you can go to menti.com and enter this number. Either way is totally fine. Just give me a little reaction when you're up so I can know when you're in, so I know who all is in or not. Anybody needing help getting into the Menti? Okay, let's go. Ooh, maybe. Oh, hold on, let me turn it on. Bummer when technology doesn't work. All right, do it old school way. Okay, let's do a couple of options. So just for fun, this or that, you choose puppies or kittens. Oh, that little puppy is just so cute. I just want to snuggle him. All right, so we're mostly puppy people, but that guy is so cute. Like, how do you not choose him? That one's cute too. What about this? Who would you rather have lunch with? You gotta choose one of these four people. Who would you choose? I think I would choose Michelle Obama too. So for those of you who picked her, we can all like have a lunch someday with her. That would be pretty amazing. What about your favorite types of sweets? Fruity, sour, chocolate, or licorice? You can abstain. Nobody with a licorice? I mean, licorice is black. Black, I have good and plenty. I'm telling you, that's not my favorite, but it's up there. Okay. How are you feeling today? Just type in just one word, couple words. We have a lot of stress, tired, anxious, overwhelmed, hungry. There's a little bit of confidence in there. I like that. Thankful, stressed mess. That kind of tells us a little bit about kind of that cognitive overload, where we're feeling before our first test. It doesn't really surprise me a whole lot that that's where we're at today. But we can offset some of that by doing what? Deep breathing. What are you going to do when you feel stuck in a question in the test next hour or next class? You're going to take a deep breath and then you're going to keep going on, right? All right, let's launch into chapter 15. So today we're covering chapter 15 and chapter 17. Chapter 15 is gerontology, like that aging process. What changes as we age? You guys did your individual projects that on your body system. And so you guys should be pretty familiar with some of these body systems already. So we're going to define aging, talk about some of the basic changes that happen in our body. There is physiological and cognitive changes. And when I say that, what does that mean, physiological and cognitive? Body and mind, right? Because you're going to see there's going to be patients you encounter whose bodies are very intact. Physically, they're doing very well, but cognitively, they're not doing so well. My grandma ended up driving herself. Well, she lived in Missouri, but she ended up driving to Oklahoma when she was trying to get to Walmart. Her body was intact, but her cognition was not, right? We were like, oh, okay, grandma can't drive anymore. right? That was an issue. There's other people who their minds are sharp. They know what's going on, but their body has not kept up and their bodies are in a not so good state. We're going to talk about how do we plan nursing care for patients that have these changes, and then identify what are the nursing practices and what are the things we do that can help promote safety for them. Because as people age, safety is one of the biggest concerns because there's a lot of issues that can happen to them. Sometimes we talk about concepts. You know, what are the concepts we're covering? Hearing, cognition, elimination, safety, self-care, sensory, and stress and coping. Stress and coping might help us too today, right? Maybe a little bit. Okay, so first we're going to say, what is aging? And I just want to start out by saying aging is normal, right? Is anybody here the same that they were 10 years ago? 10 years ago? As part of the life cycle, is that we're meant to age. We're meant to grow and mature, age, and eventually die. We're going to talk about that a little bit more in the next half of class, but it's a normal process. So sometimes people are like, no, this is wrong, like this happens or this happens. Well, it's actually part of the normal process of aging. It's unique, meaning not everybody ages in the same way. We've all seen somebody, we're like, oh, like, you're 84, like, you look like you're 50 or something, right? Like, they look really young without lots of fillers and stuff. And then we've all seen people who also look like they're 84, but they're really in their 50s, right? Like, we've all seen people that have like a different way of aging. And sometimes there's things that can affect that, right? People who look a lot older than they truly are, what are some of the things that have affected them? Stress, smoking, alcohol, sun exposure, drugs, all of those things can really affect how you age and how your body responds. Yeah, good job. The frailest adult is usually 85 and older. That's usually you can compensate or you could kind of do pretty well up until 85. At that point, we're only meant to live so long, or I don't want to say that we're meant to live so long. Our body's physiology, usually around 85, things really start to take a decline if they haven't already. And those people are the most frail and really need the most care. So, talk about our practice analysis today. What do we need to know about caring for these people? So, we need to meet the age of clients 65 and older. So that's when people are the people that write the NCLEX. When they're writing it, they want to make sure that you guys know how to take care of patients who are 65 and older, because we have a population that's aging and living longer, and we need to know how to take care of those patients as they're getting older and they're having all of these physiological changes. So with our changes, we have our cells start to decline. They're not made as well as they are remade. And then we have altered structures physically, and we're going to talk about that as we go through our body systems, as some of the structures in our body actually change. So muscular. Got a little question for you. Which of the following actions, let me make sure I say it right, should the nurse implement for aging changes in the muscular system? So if somebody's having changes in their muscular system, what do we want to implement? Select all that applies. So you can select a bunch. Develop a toileting schedule. Provide longer time for task completion, adhere to hand hygiene protocol, monitor for aspiration, provide rich vitamin D, and assist with range of motion. We have a lot of, like, a wide variety of answers here. I like this. All right, let's see. So correct answers are give longer time for task completion. That makes sense to me because muscular, your muscles, you're moving, you're not able to do things as quick as you normally would. We need to provide a rich diet in vitamin D. They need all those, their vitamins, especially vitamin D for muscle growth. And then we need to help them with range of motion. Developing a toileting schedule, I wouldn't say that's necessarily the muscular system. What system might that be helpful with? I would say urinary or even bowel, like it's like with more elimination. Adhere to hand hygiene protocols. That's always a good thing to do, but this is asking about specifically the muscular system. And so that might be more of like like immune related. And then monitor for aspiration. What system is that going to be affected with aspiration? Yeah, so respiratory. We have some things that change in our respiratory system as we age. And that would be something we would look for more in our respiratory system. So with muscular changes as we're aging, we not only have a decrease in muscle mass, meaning our all over our muscles in general, but also the muscle tone. So the muscles that we do have as we age are not as strong and as responsive as they were when we were younger. Their muscle response is slower. Their tendons and ligaments are not as elastic. They don't stretch as much as they maybe once did. They need a longer time. So the nursing implications, our range of motion is limited. When we say range of motion is limited, what does that mean? Yeah, they can't move around as much. So looking through the eyes of a nurse, right? Put your nurse glasses on. You're looking at a patient. They have a decreased range of motion. What does that mean for our patients? What safety issues might that kind of imply? Might be a bigger fall risk. Why is that? Maybe they can't move as well.
Their reaction time is slower, so when you fall, you like immediately, when you're younger, you put your hands out.
You might be able to catch yourself, okay? Maybe their call light or their phone is just far enough that they just can't, they don't have that actual range of motion to get to it, to call us. They take longer time for movements and tasks, and they're at risk for injury, right? Because they aren't as mobile. They are have a higher risk of falling or not being able to catch themselves. Let's move over to the skeletal system. Skeletal are bones, right? So when we say they have exaggerated bony prominences, what does that mean? Yeah. And we're going to talk about it more with integumentary, but you have a loss of subcutaneous fat. So that fat that we all have that kind of rounds us out a little bit. As we age, we don't have that as much. And then with our muscular system, we've lost some of that muscle mass. So all of those bones are sticking out more. So a lot of times we think about our shoulder blades, our shoulders, our elbows, our hips, coccyx, anywhere where we have bones that stick out. And coincidentally, when we're looking at patients, when we're looking at their skin, because you guys are going to be doing skin assessments and foundations sometime this term, I believe. Those bony prominences are where we really want to hone in and assess for, because they don't have that padding like we do or younger people do to help protect that area. So their cartilage starts to erode. You know, a lot of people end up having like knee replacement symptoms because they have issues. Osteoporosis. What's osteoporosis? What's that? Tiny bones. Tiny bones are like holes in the bones. Yeah. A lot of times we'll have patients, and typically it's what is it called? Small white women. I'm trying to think of what the word is, but like thin bones, but like petite. That's our typical one, but doesn't mean that that's usual. But a lot of times those patients don't have enough calcium that they're eating. And what are bones made of? Calcium. They're made of calcium, and your body needs calcium for its normal regulatory processes. And so when you are starved for calcium, you're not getting it in your system, you're going to pull it from your system. And so our bodies will pull calcium from our bones and have these little holes all through our bones. And then you can have people who have very weak bones and get a lot of fractures from that. Their vertebrae, the disc loses some water, and so they actually will shrink in height a little bit from that. So nursing implications, we want to do those range of motion exercises. So we talked about that with muscular too, but we really want to help maintain their range of motion that they have. So it's easy for the arms, right? But you know, if they only can get up to here, let's keep helping them get up to here, because if we're not moving them around and helping them stretch, use that range of motion that they have, they might only be able to get up here after a while. It's not going to increase without help, and it won't stay the same if we don't help. The warm water decreases pain. What that means is sometimes we have hydrotherapy, or we'll put people in these warm pools. Sometimes we're having physical therapy. Some places will have warm water, like, if you think about a hot tub, anybody got it, like, been really sore and you went and sat in a hot tub or a hot bath? It feels really good for your muscles and bones, and it helps with that stretching. Because of the skeletal changes, they're gonna have some of those self-care deficits, very similar to the muscular system, where they don't have that same range of motion. They can't take care of themselves like they normally would. And so a lot of these patients are on anti-inflammatories to help the inflammation in the bones. But unfortunately, a lot of our anti-inflammatories, what's the side effect of some of those? They can cause stomach discomfort. Yeah, they can cause issues. They also, a lot of them are mild blood thinners as well. And so if we have patients like even aspirin, right? We talk about giving ibuprofen. Those all are mild blood thinners. And so, we have to look at the risk with our patients. Are they at high risk of falling? What happens if they fall and hit their head and they're on a blood thin? Maybe not so good, right? They might end up having some more serious issues. So it's kind of just weighing out what is best for the patient. We want to make sure they have good nutrition for bone health. So that's what a lot of times we're talking about calcium as well, making sure they have that calcium in their system. We want them to do weight-bearing exercises. Do you guys know what that means by weight-bearing exercises? Yeah, so right now I'm doing a weight-bearing exercise. I am moving around, I am bearing weight on my skeletal system. If you are sitting and you're kind of moving back and forth with your arms, you're not really bearing weight. If you pick up a weight with your arms, then you're bearing some weight there. But if you think about like more bigger motion, actually working those muscles and bones, and not like the gym people who are like benching 500. I don't know what that means. Like, I don't know what that is, but like, it's not about going to the gym and seeing how heavy you can lift. It's just about getting up, moving. They might need some ambulatory assistive devices. What might those be? Yeah, walker, a cane. Sometimes they have those little walkers they can sit on. They need to rest for a little bit. And we always want to make sure that people that have these big skeletal changes are labeled as a fall risk, because we want everybody to know, especially, well, I don't say everybody. If they're out in the community, they're out. But if they're at a nursing home, a hospital, a care center, we want to make sure we have things labeled so that everybody on their care team knows they're a higher risk of falling. We want to protect them. So one of those practice analysis tips, I want to make sure you guys know how to assist with daily living activities. All right, now we're going to go into integumentary. What is integumentary? Skin. So some of the changes that happen with skin. The skin actually thins. So does the hair, right? We've all seen that in men and women both. Decreased subcutaneous fat. But usually I like to look at the hands. They're a pretty good example. I've even noticed in the last 5 years, like, oh, my hands aren't as like plump as they used to be. You start losing some of that subcutaneous fat that you have. You do have increased dryness of your skin and nails. You don't have as many sebaceous or sweat glands. People that are older don't tend to sweat as much. Because of that, sometimes there's some issues regulating the body. We really want to make sure that we are monitored for that. They start decreasing how much melanin they produce. And so that's where we see a lot of gray hair start to form. This is a picture of that thin hand, right? This person, 40 years before that, their hand probably would have looked more like mine or any one of ours, where it has more of that subcutaneous fat in there. This is just a really good example because it's so obvious. But if we think about some of those bony prominences, like our coccyx, our hip bones, back of our shoulders, when we lose some of that muscle mass and some of that subcutaneous fat that cushions us, you can see how, wow, like there is not a lot cushioning or helping to protect the bones from pushing in on things. So some of our implications, like what does that mean for us as nurses? So if we're putting on our nursing glasses again, what does that mean we have to do? So they're going to have longer healing time. They're not going to be able to jump right back into normal life like a younger person would. They also oftentimes have chronic diseases. We're going to talk about a lot of these as we continue through our MedSurg classes, but those chronic diseases are going to affect how they're able to heal, how they're able to recover. They might end up having pressure injuries. And so that's where we talk about, that bone pressing down, and it just depends, like pressure injuries happen wherever there's pressure happening, or they can. So if somebody is laying in bed and they're supine, they're on their back, where are areas that might be risk for pressure? Their heels, tailbone, shoulders, elbows. What about if they're sitting in a wheelchair? Yeah, kind of their bottom. Sometimes if they've overgrown their wheelchair, maybe the sides too, that might be pushing in on things. Their heels feel the bottom of their feet. You want to look wherever there's pressure happening because they're a bigger risk of it. And if they have some of these disease processes, like diabetes, that might affect sensory or how they're feeling some of like that input, they might even be higher risk. People get pressure wounds on their ears too, absolutely. People who wear glasses or have chronic oxygen, you always want to look behind anything that's there because people can get pressure injuries. And a lot of times people don't look back there because it's a little more difficult to see. It's not so obvious. Yeah, that's a great point. We want to make sure we're doing gentle bathing because that skin is thin. It doesn't have as much subcutaneous fat to kind of anchor it down. And so there can be shearing that happens. And so if you think about that thin hand that we saw, if you took that and just kind of pulled it really hard, potentially that skin could shear away. And so we want to be really careful as we're moving people in bed, as we're positioning them, as we're taking tape off of their skin. Maybe they had a lab draw, we're going to take that tape off. It's very easy to damage that skin. So we're going to be very gentle with them when we do how about that? Oh, they're saying as far as bathing, you might not want to submerge them in water at times if they're having a lot of issues with their skin, because that might even be more draining for them. So you might just bring the water to their bed and do a bed bath. Again, some patients might really benefit from a soaking because of that muscular ache that they might have with the skeletal aches. So it's always kind of weighing what are the risks, what are the benefits for our patients. Cardiovascular. I love the heart. It's so fun. You see arrhythmias. I had a gentleman, I was in the nursery at church snuggling babies because I don't have babies anymore. So I go to my church and I volunteer in the nursery so I can snuggle the babies there. And my friend came and got me. She goes, I need you to go see my husband. And I was like, okay. Like, I mean, when you're a nurse, you're going to find that people come and get you for all kinds of things. And so you never know what you're going to walk into. I'm just really glad they didn't want to show me something because that always gets really weird. But he was pale. He was diaphoretic. He was sweating. He said, I just don't feel good. There's something wrong with me. So I sat down. I looked at him. I felt his pulse. It was really high. Do you have any heart issues? He goes, no. I have some, he had some, some plaque, and he was on like a liquid or something for helping that. But he said, no other issues. So I put my watch on him because my watch has a little EKG function. And he was an AFib. I kind of figured he probably was because usually, his heart rate was really fast, but it was also irregular. And I was like, okay, yeah, you're an AFib. And so he was so funny. He's like, okay, I'll go to the hospital. I was like, okay, your wife will drive you. He's like, I think I'm fine. I'm like, well, but you're not. And so they went to the hospital and he was put on some medication, and they actually were going to do what's called a cardioversion, where they use electricity to convert you back to right rhythm. They shock you. He actually converted before that, which is really nice when that happens. The medicine that they give you can kind of catch up and work. But he's older. He had never had those issues. Sometimes stress can be one of those things that can bring it on. And he had had a lot of life stress happening in his life, and his heart went into an arrhythmia. Younger than that, early, he had never had that happen before because his body was able to compensate and be able to work normally still. But as he's aged, his body wasn't able to compensate as much, and his heart did go into that arrhythmia. He's doing fine now. He's on a medicine to keep it nice and stable, doing great. It's always nice when you have a happy end to the story. Your blood vessel elasticity decreases. We're going to talk more about that when we talk about cardio and the implications for blood pressure and things like that. Your cardiac output decreases. What is our cardiac output?
Force.
It's just how much is coming out of our hearts, right? Our left ventricle pumps blood out into our system, and then how much is coming out. That in general, the amount that's coming out lowers, yeah? It depends on every person, right? So I can't remember if 5 liters is right around there, but for somebody who is 5'2" versus 6'2", there's going to be a big difference in cardiac output because the person who's 5'2" only needs a smaller amount of blood, while the person who is 6'2" needs more blood because they have more mass to oxygenate. So it varies how much output there is, but good question. Their cardiac conduction time increases. Cardiac conduction time just means that electrical symbol, not symbol, sorry, signal. So at the top of our heart, we have it's called the SA node. We'll get more into this in cardiology, but it sends an impulse that makes our atrium contract. And it goes down to our AV node and it makes our ventricles contract, or it goes through there to make them contract. That doesn't happen as fast as people get older. So you might see some slowing of the heart rates or more potential for those arrhythmias. Their leg veins, the valves, become less efficient. So when our valves are less efficient, what happens? Yeah, the blood's not going to pump back up as easily. And when you have blood that's kind of sticking around in the legs, what does that look like? Swelling, edema. Makes them more at risk for getting a blood clot, having skin issues. And then classic symptoms of cardiac emergencies or altered. That just means typically if somebody's having a chest, like a heart attack, they might clutch their chest and say, oh, I feel like I'm having a heart attack. That doesn't happen for everybody, especially women are different in how we present. Older people are a lot different in how they present with their classic cardiac issues too. So we really have to look at patients. If there's something, I've just been really tired lately, that might be a symptom of something going on with their heart that's not one of those classic symptoms. So implications, fluid balance. We want to make sure they're getting enough fluid, also that they're urinating enough, getting enough off. They might have edema, like we talked about with their legs. So elevating their legs above the heart is helpful. That helps it to flow back into the system and get redistributed. What is orthostatic hypotension? You guys learn this in foundation?
Drops.
Yeah, when does your blood pressure drop? Yeah, when you stand up. So why would that make somebody at higher risk for falling down? It's like they pass out, right? They stand up and they go, ooh, not so fast. And then, oh yeah, we already talked, they have different cardiovascular symptoms. What they're saying they experience is different than what younger people might experience. Respiratory. Oh man, I thought I put more questions in here for you to answer. I'm sorry, guys. Emptying of the lungs less complete. When we did our deep breathing and we blew out, we can blow out a lot. Older adults, they kind of lose that ability to be able to empty their lungs all the way. So it actually almost kind of diminishes what their total volume and capacity is in their lungs. The lung recoil strength, gag reflex, all decrease. Their cough is increased. What does that mean for when they eat? What does that mean for us as nurses as we're helping them to eat? They're much higher risk of choking, higher risk of aspirating, because if something goes down the wrong way, they don't have that cough to get it out like you or I would. With the gag reflex, or their gag reflex isn't as strong to maybe keep it from going down. They don't have that same cough to get it out. And then respiratory, it takes longer for them to recover. If me and my mom ran up the 4 flights of stairs over here, I would be huffing and puffing, but I'd probably be okay in a few minutes. My mom, however, would probably take, well, first of all, she wouldn't run up the stairs, right? But she still would be huffing and puffing for a while because it takes her longer to recover. So nursing implications, we really want to hammer down on our patients. Hammer down sounds really aggressive, but we know that smoking is really bad for our lungs. And so we really want to encourage our patients people who are still older, 70s, 80s, that still smoke. And so we just want to encourage them, hey, come join us. There's KWL in the back table. We really want to still encourage them to stop smoking. Because even if a lot of patients might say, I've done it my whole life, the damage is done. What is that? What are maybe some responses we could say? There's still time. Time for what? Still time to quit. Right? Or maybe the damage has been done already, but you still want to continue to damage your lungs, right? There's always ongoing damage. Your lungs can rehab quite a bit. The longer that you smoke, the less their amount they're able to rehab. But it's always better for patients to stop smoking if we can help them with that. Activity intolerance. So my mom, she can't run up the stairs. So we're gonna pace her, right? If I knew my mom had to go, and my mom actually has some respiratory issues. If I knew she had to go upstairs, we couldn't take the elevator, I might be like, Mom, it's such a pretty view. How about every floor? Let's just take a minute and like look at something. Like let's play I Spy, I don't know. And then we'll go up another floor and we'll take a minute. We're gonna pace ourselves because I know she's not gonna be able to go up super fast. We're gonna get those periods of rest. They're more at risk for infections as well. Not only because they don't have that capacity to breathe in and out as much, but because they are higher risk of having little bits of aspiration, little bits of food or fluid go down in their lungs. They're not able to protect that or cough it up as much. So we really want to promote some health maintenance or health prevention, excuse me. Health maintenance is more like, hey, you have your lung disease. Let's talk about how we can keep you as healthy as possible. What are some breathing techniques and breathing exercises you can do? What are some medicines you really need to keep taking? Health promotion is like, hey, let's do a flu shot or a pneumonia shot because we know that's going to help protect you from getting the flu or getting pneumonia. Gastrointestinal, GI. That's another term you might see people abbreviate. There's going to be lots of abbreviations. Are you guys doing medical terminology in the support class or part of it? Yeah. Okay. So those are really important terms. Like you're going to see as you go through clinical or SIM or some of your tests, you might even start seeing some of these medical terminology pieces. So GI is gastrointestinal. So unfortunately, taste, smell, and saliva all decrease. Their gastric emptying is delayed. So that means their stomach, we all eat a meal, it goes through our system. For people that are older, that time for that food, that meal to empty their stomach is a lot slower for them. Peristalsis. What is peristalsis? Yeah, it's a wave-like movement that's your intestine, small intestine to large intestine that will move fluid through your GI system, and that's delayed. And then your liver enzymes actually decline as well, which means that your medication isn't going to metabolize as fast. So sometimes we'll have, I think they call it geriatric dosing or older adult dosing, where maybe 50 milligrams of this medication worked really well for this person. But now that they've gotten older, they're actually not metabolizing it. They're not getting it out of their system as quickly as they used to. And so now 25 milligrams is enough because that 25 milligrams is sticking in their system longer. Yeah.
So is this like baseline for everybody that's old? Or is this just for like people that have severe medical issues?
This is baseline for everybody. Everybody, as you get old, you're going to experience all of these. But the degree you might experience them might be different. So some people might have really good smell. Other people might have almost no sense of smell. There's a wide variety of how people will encounter this, but they will still have a decreased sense of smell overall.
So much to look forward to.
It's a lot to look forward to, isn't it? So nursing implications, nutrition. A lot of times when we can't smell or taste things as well, anybody lose their sense of taste when they had COVID? Or if you had COVID, yeah. Was it as fun to eat things?
No.
I had a lot of people say they lost a lot of weight when they had COVID because they couldn't smell and taste things. And they were like, why eat? And so we see that with a lot of our patients. Yeah.
I have a question.
Yeah.
So when I was pregnant, I feel like all my senses like got heightened.
Yeah. It's very normal. Yeah. Yeah. Very normal with pregnancy.
Now I feel like it can smell better than I ever smelled. Like if my kid was like over there and he had a PM,
Yeah.
I could smell it.
I don't know about that piece, but I know there's like mommy sense or like mom sense where you're just like, you know, you could have 100 kids saying mom and your kid says mom, you know, right away. Like it's, there's certain things our bodies get attuned to. So with nutrition being an issue, it's a lot of times, think about that peristalsis and the gastric emptying being delayed. It's slower getting through the system. So food is in people, the older people's system longer, meaning they're not as hungry, right? They're like, I ate lunch and it's dinner time and I'm still kind of processing all of this. We really want to make sure that we're making, first of all, food appetizing. You know, how things look on a plate is very important to people's appetites. You know, I like to say you eat it with your eyes first, you know. But we also want to make sure we're adding seasoning. A lot of our patients can't have a lot of salt because of their heart issues. And so we want to look at some other things that might make the food tastier. And then we also want to make sure that we're getting them compact nutrients. So things that have a lot of nutritional density, meaning I want to make sure they're getting a good protein, healthy vitamins, carbohydrates, whatever they need, maybe in a smaller amount. I'm sure you guys have seen like Ensure shakes or dietary supplements. A lot of times people will, that's just, they'd rather just drink one of those. Not optimal, but at least it does have a big, dense nutrition value for that. We might have a dietary referral. We might look at our patients' specific dietary needs. So we're able to look at all their medical issues and kind of come up with a plan for that patient. Oral and denture care. That's another issue. If somebody doesn't have all their teeth, that might be an issue why they're not eating. They can't chew. Or that they have sores in their mouth. It hurts to eat. So we want to make sure we're looking at the mouth, saying, what do we need to do to help these people with eating? Monitor for drug toxicity and monitor for constipation, because as peristalsis slows, that also means that pooping slows too. They're not, really, a lot of older people complain about constipation. And it's true. Older people will have constipation, or they won't have constipation. Their GI system slows enough that it really can make them a lot more risk for constipation. Endocrine. So they don't have as much insulin that comes out, and their glucose, they don't tolerate it as much, meaning their body doesn't make enough insulin. They don't pull the glucose into the cells as fast. So they might have some hyperglycemia. What's hyperglycemia? Higher blood sugar. Yeah, you might see people with higher blood sugars. Their adrenal hormones aren't regulated as well. And so they might have a decreased response to stress, meaning they're not able to handle it as much. Their bodies aren't able to handle it as much. My friend who had the heart issue, right? He was having a lot of stress and his body wasn't able to regulate it and actually spilled over into his heart to cause his heart to have an arrhythmia. Your metabolic rate slows. Some of you guys are young, some of you are not so young. I used to be really young and I used to be able to eat McDonald's every day. And then maybe I'd run once a week and I was fine. I could never do that now because I would feel horrible and then I would never fit into any of my clothes. Your metabolic rate actually slows as you get older. So we're going to look for hyperglycemia, try to reduce those stressors, encourage weight control. Sometimes the heavier that people are, the harder it is on a lot of their systems. And so we want to help them try to have a healthy weight. Thyroid problems can often be undiagnosed in patients because that can also just kind of their general symptoms. So we want to make sure we're looking at patients' thyroid function and maybe saying, hey, talking to our providers, have you checked thyroid? Have you seen this thyroid level? What's going on? All right. So which system might contribute to drug toxicity. Note, I did not put the, is it adrenal system on here? Cognitive, genitourinary, neurological, immunological. All right, we've got neuro, super interesting. Yeah. Oh, gosh. So actually genitourinary. I know, so. So this question I felt was a little bit tricky, but it did come from the publisher, from F.A. Davis, and so I felt like it was good to talk through it. Yeah, I know. So if it had said hepatic or looking at the liver, we would have been like, yeah, we know that. But our renal system also function as a filter as well. And so as somebody's kidney function decreases, they're not able to filter out and pee out a lot of some of these metabolic waste or drug wastes. I can see where the argument could be made for cognitive, saying somebody is confused and maybe they're taking too much medication. Or neurological, I don't know about neurological, to be honest. Like if you're saying maybe that's confusion or that's they're not knowing when to take their medication, I could see where that would be an issue. But the correct answer is genitourinary because that's going to impair them from it's going to impair them from filtering out the medication.
So when we see genitourinary, these things are included in the renal system.
Yes, yeah, genitourinary is always going to be including renal system. Yeah, good clarity. So that's a good thing. If you didn't know, like GU or genitourinary, that's talking about genitalia, but also urinary. They're all treated as one system. Yeah, and kidney. I don't think I said that right. Kidney. So bladder, kidney, all those. So some of the issues with genitourinary, benign prostate hypertrophy, you're going to see that as BPH sometimes. That's where in men, the prostate will enlarge and it presses in on the ureter and it makes it more difficult to pee. So a lot of times these patients have very well functioning bladders, but the prostate is pushing and it won't let the bladder release or get rid of all that urine. So sometimes they'll take medication, sometimes you have to actually have surgery to decrease the size of that prostate, but it can be very difficult for those patients. The bladder size and tone decreases. So tone, kind of like muscle, right? Like we can maybe stretch and we have tone to be able to handle maybe more urine. But if you don't have the same muscle tone in your bladder, you're not able to handle as much urine in your bladder. And you've got to pee quicker or more frequently. You can't handle as much in there. Your kidney filtration and function decrease. So they're not going to be able to process as much liquids. Your pelvic floor muscles are weaker. This usually affects more women than men just because of how our bodies are situated, but also because if you've had children, that can stretch out and weaken some of those pelvic floor muscles during childbirth. Incidences of urinary tract infections increase, and then their urine concentrating ability decreases. What does that mean for us or for how we're taking care of our patients? They're going to have more nocturia. They're just going to be usually peeing more frequently. Their bladder tone isn't there, not concentrating as well. Except for men with BPH, they're going to just be, they actually pee a lot because their bladder is full and they just are trying to get that urine out. We want to monitor for drug toxicity. There's going to be more incontinence. So usually shorter voiding urge signal time. What that means is you're sitting here and you feel like, oh, I kind of have to pee. And then you think, wait for the birth. Maybe I can make it 5 minutes. As we get older, that urge goes from 5 minutes to, I need to go right now. Like I don't have that time to wait. So they don't have that much time. And then patients will also often avoid fluids out of fear of accidents. I knew that with my grandma. Anytime we took her anywhere, she would be so thirsty that she would never drink anything because she didn't want to have an accident or wet herself while she was out. So we're going to talk about Kegel exercises with our patients that have the pelvic floor weakness, help them to strengthen that pelvic floor. And we also want to talk about safe toileting, because if they're going to be up to the bathroom a lot, we're going to say, okay, how are we doing getting up and down? Are there muscular or skeletal issues? Do they need a grab bar to help kind of lower themselves to the toilet? Are there rugs in their bathroom that they might trip on? Immunological, our immune system. So our autoimmune response increases, meaning how they attack things inside their system. Their immune response actually declines. So they're more likely to attack something inside of themselves, less likely to attack something, an invader, like the flu virus or pneumonia, something like that. They're not as able to respond to an infection. Nursing implications. We might see more autoimmune disorders because they are more likely to signal something else as an issue inside their body that's normal. We'll talk more about autoimmune issues. I think it's MedSurg 3. We're not going to get too into it right now. Questions? No, scratch your head. Got it. We want to make sure they're maintaining their immune vaccine schedules to help promote safety for them. Okay, guys, we're almost there. We're going to take a break. Hang with me. Less than 5 more minutes. Neuro. So unfortunately, we're all losing brain cells as we get older. So this will slow down our processing. We're going to have decreased blood flow to our brain as well. Our endorphins decrease, equilibrium and motor control, that all decreases. Reaction time and sensitivity all decrease. So all those things, all that input and how we're able to manage it, it's all slowing down. So we want to help them with their activities of daily living. A lot of assistive devices, we talked about the canes, the walkers, other things with, sometimes with feeding, you might have some spoons or things that are bigger that we can handle more easily, do that dexterity. Altered temperature regulation. Sometimes they can't feel when things are hot or cold as we would be able to feel. If people are living at home, we want to make sure they have things like their water temperature set at a safe level. I know some people here probably have their water temperature set scalding because you want it really hot. But with our older patients, they can't feel that as much. And so if they try to step into a bath, they could actually accidentally burn themselves from that hot water. I don't know, this is kind of weird. I haven't seen these in practice, but there are things like this that would help feed patients that don't have that dexterity and ability to feed themselves. This is like a assistant device. Anybody seen something like this? No? I showed it because I thought it was kind of interesting. You know, maybe there'll be something like this that we'll see eventually. However, we will see some things like this. A lot of occupational therapy will give patients things to help them put their socks and shoes on because they don't have that mobility, the stretch, the ability to put on their socks and shoes. They might have things like they can't hold a hairbrush. They have arthritis. They can't physically wrap their hands around the brush. But there's a little sleeve that they put their hands through, and then they can still brush their hair or do, you know, maybe brush their teeth, something like that. And then this is a food guard where it kind of keeps all the food on the plate because they might not be able to pick it up as easily, and you don't want them to like shove the food all around like the table. So just a few examples. Sensory, how we're feeling things. So decreased visual acuity. As we get older, people are more likely to have glasses because they don't see as well. And please, if you're going in and doing AM care for anybody, please ask if they have glasses or see if they have glasses. And before you help them put them on, make sure they're clean, right? There have been a lot of people who are like, they're just not seeing well. Then you look at their glasses, you're like, holy moly, nobody could see through these, right? Make sure they're clean, that they can see through them. They're going to have decreased elasticity in the eardrum. You have to be able to hear quite as well from that. Like we talked about, their taste and smell, but also their touch, their sensation, what they're feeling. Not just their hands, but their whole body is decreased. So we're going to make sure they have their glasses or hearing aids. They might have some anorexia where they're not eating. We already talked about some of those things. We're going to try to help them with healthy nutrition and keep them safe. Sexuality, we're just going to talk about briefly. chronic illness can really have a big effect on patient sexuality. For men, sometimes it's altered ability to maintain erection or ejaculate. Women, their vaginal lubrication and acidity is both decreased. So we want to talk to patients about, maybe intimacy is not, or sexual intimacy, they're not able to have sex. So maybe we're talking more about, hey, what about touch with your loved one? You don't have to have actual intercourse to have some of these like sexual exchanges with people or with patients or others. Psychological factors can be a big influence, and time for arousal can be an issue for our patients. So for our patients, we want to meet our patients like Maslow's hierarchy of needs. Sexual intimacy is one of those baseline Maslow's hierarchy of needs. So we want to make sure their needs are being met. We want to also understand what are patients' personal values. Are they open to even talking about this? We want to avoid stereotypes. We want to support their maintenance of their sexual identity, and then also provide some scheduled privacy for them by themselves, with their loved ones, whatever that may look like. Which of the following actions should the nurse implement to meet an older patient's sexuality needs? Select all that apply. Are we limiting visitors? Providing physical privacy?
Provide memory aids.
Provide memory aids.
Oh my God.
All right, if you didn't answer, I went ahead and just pulled it. So no, we don't want to limit their visitors. We do want to give them scheduled privacy. We don't want to share our own personal sexual values with them. That would be inappropriate. We don't need to necessarily provide memory aids, but we do want to finish data collection with sexuality. Actually looking at that question going, why did they word it that way? I think what FA Davis is getting at is saying, you might not want to lead with a sexual history, like when you're talking about your assessment, right? That's probably going to close people down pretty quick. But once you have finished your assessment with your patient, you've established some rapport, that might be the opportunity to then go into what their sexual, health history or health is at that time. And then discuss safer sex practices. Sometimes this doesn't seem like such a big deal, but there have been lots of outbreaks of STDs in older adult homes because those older adults still have sexual needs and preferences. And a lot of times they share those needs and experiences with other people in the home. And there have been STD outbreaks. And so we want to make sure they're talking about what is safe sex. A lot of these people maybe didn't get that education in school or with their families. And so we want to help provide them with that. Cognition, our ability to think and process. So storage, processing, and retrieval of information is all declined. So sometimes somebody might ask me a question. I'll just say, hold on, I'm retrieving. What's the answer? For older adults, it just takes longer to remember, to think through, to get to what we're saying. It can also be affected by things like pain, medication they're on, a lack of sleep, right? I'm sure if anybody here had to stay up all night, or maybe you did if you were studying, you might feel a little delayed, and that affects everybody. Their short-term memory can be impacted. So for our nursing implications, we want to make sure we're using some memory aids with them. A lot of times, I don't know if you guys have seen their boards people have in some of their rooms with like memory care, and they'd be like, hey, my name is so-and-so. I am at this place. Today is Sunday. Kind of give some help with people remembering. Their coping abilities, they're going to have a lot of changes in life. We all have a lot of changes in life, but by the time we're older, we've experienced a lot, and our ability to cope might decrease with that. Role change acceptance. I think we talked about that a little bit last week about, for hiring or for moving to a different role, sometimes that's hard to accept. There can be a lot of turmoil there. They might need some encouragement. They might need some help with developing some coping techniques. Depression is really common in our older adults. It's the most common psychiatric problem. It can really be influenced by change or loss. So maybe they're moved to an adult care or an assisted living or they've lost a loved one. That can really, cause increased incidence of depression. It's very treatable though. And we want to make sure we're monitoring for depression in our older adults, and then we're reporting it to the RN, to the provider, to somebody, so that we can kind of keep treating them. All right, we're not going to do this because I want to give you guys a break. So dementia, it's a permanent progressive loss of some of our mental functioning. It can be, it comes in a variety of different forms. You guys have probably all heard of Alzheimer's. That's one type of dementia. Lots of different forms. So just know dementia can look like this for one person, and it can look totally different for another person. So you don't want to just assume somebody with dementia has all loss or not very much. You want to kind of see what is their, probably your best way of determining that is to look at the chart or the report from somebody else. You want to make sure we have physical and emotional safety. Dementia is really tough when those patients have had their very good physical function intact. Their bodies are active and good, their minds are not. And that's really scary. We want to provide reality orientation as appropriate, and we want to educate and support the family. My grandma ended up having Alzheimer's, and she lived with my mom until she passed away. But grandma would try to leave the house at 2 o'clock, or she would try to start cooking dinner at, midnight, and then she'd walk away and leave the stove on or something. And so there's all these things that you can help support families. There's actually a doorbell my mom put on my grandma's door. So in the middle of the night, she got up to go do something. My mom would wake up and kind of help redirect her to something appropriate. So one of those practice tip analysis, we're going to participate in reality orientation. And some of that just saying, hey, grandma, it's midnight. Why don't we do dinner a little bit later after we sleep? Let's do it tomorrow. Just gentle reorienting. So delirium is different from dementia. Delirium is temporary, and it's usually related to something happening in that moment. Temporary stress, like hospitalization, illness, medication, something that's causing that delirium, and it's treatable. It can go away. It's usually sudden onset, and patients will often, if they're really scared and they're really frightened. Usually it gets worse at night. Sometimes they call it sundowners, and they get a lot worse. All of it. Dementia can also have some sundowning effects too, but I feel like we see the delirium, especially at night. You can also see this documented as confusion. So we want to see what are the risk factors for confusion. Why are they having this, especially if it's sudden? If this patient doesn't have a history of any other cognitive changes, and all of a sudden they're suddenly having these, I think they probably are having some delirium. Yeah.
So does this happen as well with patients with dementia? Like my grandmother would wig out of us at different moments of the day.
Yeah. So if she has dementia, you can have some triggering responses.
Yeah, she would be like, the Indians are coming over the hill. And I'm
Yeah.
like, what in the world are you talking about?
Yeah. And then you want to reorient
Mhm.
them. Yeah. So delirium is usually more sudden and onset, and somebody can have dementia and delirium, which makes it really tricky.
Yeah, like when she wouldn't sleep, when
Mhm.
my grandmother, some of her medication would just keep her up for days.
Yeah. And the lack of
And
sleep can trigger it too.
She would hallucinate and
Yeah.
doing all type of weirdness.
Yeah. There's a patient I took care of when I was a baby nurse that he had a hip surgery, I think. And he was bonkers. He was just he thought that the pictures on the wall, the people were coming out to get him, and we were having to tie him down for restraints. He was crazy. And then I was off for a few days, and I came back. He's walking in the hall. And he's he was so with it. I was like, what? That was the first time I really experienced that acute delirium, and then getting to see the other side. But from his surgery, that triggered a delirium, and he came out of it, which I'm really thankful for, but it can be very scary. Yeah.
What about infections? Is that delirium or is that something else?
We usually don't call it delirium, but it is a confusion or an altered mental state related to the infection. Yeah. Usually when people come in, to an ER, or they just start having sudden onset of confusion, first thing we're gonna do with an older adult is check their urine, because a UTI can often be, one of the first symptoms, not urgency or burning, it's confusion. All right, I'm gonna keep moving because I want you guys to get out of here for a break. Which of the following intervention for sleeping difficulty should the nurse use for a patient who's 78 years old? All right, ready? Everything but milk. Everybody thinks a warm glass of milk helps with sleep. It actually doesn't. Mentally, if that's what they're asking for and that's going to give them comfort, sure, give it to them. It hasn't been proven to help with sleep. Obtaining their sleep history, like what normally works for you, what doesn't, what hours do you normally sleep, that can help. Giving them a back rub or foot rub, letting them have a nice little soak before bed, or offering a sleeping pill, right? A lot of patients do have trouble sleeping, and if the provider has ordered that, it's indicated. Sleep and rest patterns are altered. A lot of times patients will flip and want to sleep during the day and be up at night. We really want to promote sleeping in a normal cycle, like sleeping at night, and being up during the day.
You just said, and go back to the other slide.
Yeah.
Everything but milk, and then on there it says AIDS, milk.
Yeah, I don't know why it said that. I'm sorry. I'm going to blame F.A. Davis for that one. Medication management. So just know, as we get older, there's a lot of issues. A lot of times those issues are treated with medicine. If you have 5 different issues, you might have 5 different medications for those different issues, and they might all interact with each other. So we want to make sure we're looking to see, do those medicines actually alter each other? Are they maybe causing increased sleepiness or drowsiness? Because they're all kind of doing a little bit of that, but all together, they're really doing a lot of that. We want to consult family caregivers and the pharmacists, kind of everybody on board, so we all know kind of what the plan is and reinforce that teaching. We talked a little bit about health promotion. Want to give them some education, screenings, immunization. We're not going to do the SBAR. I'll publish this so you guys can look at it later. So which should the nurse have in the safety teaching for a 68-year-old patient that has a decreased sense of smell? Somebody can't smell so well. What should they have? What safety should they have in place? All right. I think I misdid this because I know carbon monoxide detector is on this, right?
You still can't smell it though, even if.
Oh, that's right. Carbon monoxide is not what's it?
It's not sensory. It is sensory, but it's not, because you can
You
pass
can't
out.
actually smell it.
You can't smell it.
Yeah, so carbon monoxide detector, they should have one, but it's not related specifically to sense of smell because you can't smell carbon dioxide. I was thinking smoke alarm. They can't smell smoke very well. So you want to make sure they do have a smoke alarm. And then they want to read labels before ingesting anything. Meaning, if they have something old and funky in their fridge, they might not smell that like we would smell it. So I want to make sure they're reading for like use by labels. They don't eat something that's past its prime. That makes sense? All right. Moving on. Which of the following identifiers should the nurse use to reduce medication errors? What could we use as medication identifiers? Yeah, all right, you guys did pretty good. So they're assigned numbers, so like a medication record number, a medical record number, their birth date and their name are all pretty standard. Their telephone number can also be used because it's personal. It's just for their number. That's less used. room number, we don't really want to use room numbers because that can change. We can move people around. And then mother's birth date, nobody chose that because that would be her identifier. Okay. Exit. How do you feel after today's lesson? You can choose to put this in, and once you're done, or you don't have to, let's go ahead and take 10 minutes and we're going to come back for an activity. We still feel sick. I'm sorry. Okay. We're still scared for the test. We're maybe feeling a little bit better. We hate F.A. Davis.
I got off at 4, but that's like.
Yeah.
Can I get one of the KWL?
You know what? I printed some more. I would just put K and W
Oh,
and then L, and then we'll just, yeah,
okay.
yeah. I'll know that you did that and
Okay.
it's fine to submit it online.
Oh,